Olá,
Hello.
hello Sally.
Hello,
Hello.
Raquel.
Sorry for this. I'm so sorry for this minutes of delay on my
No
behalf.
problem. No problem at all.
Thank you. Thank you for understanding.
No problem. Everything is okay. Let's start.
Filipe, a apresentação vai ser feita em inglês.
Inglês,
A
inglês.
minha inicial,
Inglês. Sim, inglês.
toda ela? Ok.
Sim. Okay?
Muito bem.
We can start.
We can start.
Mas
Hello, everyone. Yes, we are going to start. Hello, everyone. Good afternoon to you all, ladies and gentlemen. It is with great pleasure that I am here today on behalf of the Portuguese Association of Hospital Managers to welcome you all to the second webinar of our webinar cycle from this edition of the program Mais Valor em Saúde, the fourth edition. This program, as you are aware, it was born from the need that the professionals, the healthcare professionals, the managers, and the political decisions to transform our healthcare system, our healthcare national system, adopting the value-based healthcare model. And as you also are aware, in a very short description of what is value-based healthcare, it focused on optimizing the healthcare while focusing on the results that matter to patients. So on focusing on the creation of value and while using, of course, the resources available in the most efficient way. I have to tell you that this is our fourth edition, and all this effort of this project was not able to be completed without the strategic partnership with all our partners, naming the biopharmaceutical company Gilead Sciences, the Executive company, the Vision for Value also company that is with us today this year for the first time, and with technological also support from MAIS Enterprises. And to all those, the four companies, we express our thank you for the commitment and dedication in terms of helping us to create the culture for healthcare. Since the beginning that this project is focused on three pillars. The first pillar is training. So since the beginning, each year through training sessions, through webinars, through presential sessions, we have been able to capacitate healthcare professionals with the principles and the methodology of value-based healthcare, allowing them to identify potential initiatives and potential projects for that. The second pillar is the implementation. And we have been doing that also through handling four scholarship, Mais Valor em Saúde Bolsas. Each year we hand out four scholarships, 50,000 euros scholarship, and we have been supporting the teams from the national healthcare system in the implementation of projects that apply the value-based healthcare methodology with the support of the companies Exigo and Vision for Value. And the third pillar is regarding the continuous improvements, because after all, what we want to do here is to focus on continuously improving our healthcare indicators, our outcomes, and the satisfaction of our users, while we are providing a culture that is focused on the patients. With webinar cycle, online webinar cycle that we initiated this week, we have been focusing on the pillar of training. And this year, with this new format, this online format that is allowing us to be more flexible and that allows us also to reach more professionals all over the country and to build this network in value-based healthcare. So on Monday, we have Daniel Haber with the experience of Unimed Franca from São Paulo, Brazil. So the experience of a very big private hospital group. And tomorrow we will have Catherine McLean with the example of a specific hospital with a surgical profile on orthopedics from the US. But today we have here with us Sally Lewis that will explain and give share her experience on the NHS Wales. So Sally, thank you so much for being here this afternoon with us. And to let you know that we are counting with you. We expect you to participate actively in this webinar cycle with your ask questions, also with your comments, with sharing your projects and your ideas. And that is the only way that we can grow together and to practice the change that we want to see in our healthcare system. And finally, I will end this short welcome session by thanking all the entities from National Healthcare System and all the professionals and the teams that have been with us since the first edition, developing their ideas and projects and sharing the good practice they have identified. So on behalf of the Portuguese Association of Hospital Managers, I thank you all for your presence and your willingness to be here with us, and I hope this will be a great webinar. So thank you. Back to you, Philippe.
Yeah, so thank you, Raquel. It's always a privilege to be here among very good friends and good fellows, and to be again in a webinar. And today particularly because to have this distinct entity, I would say that among value-based healthcare, which is Sally Lewis, a very good friend and a very knowledgeable person that knows really what's value-based healthcare. It's a privilege. So Sally, it's a huge privilege. I could not say better than saying that Sally, you know, is the founder of Kentucky International, a distinct leader in the field of value-based healthcare. She has a remarkable career with more than 30 years as a general practice medical leader and policy advisor. She has dedicated her career in transforming healthcare systems worldwide. She knows what's an international field, and now she's part of international consultant on value-based healthcare on transforming. She's a professor in value-based healthcare in Swansea University, and now she's a former national clinical director of value-based healthcare, Prudent Healthcare in National Wealth. Former, not. I'm lucky. We are lucky to have Sally in the world and not just fully dedicated to his system. Thank you very much about that. And she was founder of the International Recognized Wealth Value in Health Center, and she has pioneered and implemented value-based healthcare for a lot of clinical and different kinds of methodologies, and making a substantial contribution to the global healthcare improvements. Then she has worked with well-recognized institutions such as the World Economic Forum, Harvard Business School, OECD, and some others. You know, I cannot find some curriculum that can bring this much more depth about value-based healthcare than Sally. Sally, thank you very much. You know that for me it's a huge privilege to have you here and to have the possibility to share all the knowledge that you have among all these stakeholders. Thank you very much.
Thank you, Philippe, and me too. You know, I left NHS Wales to come and work with you. This is what it's all about. So let's share my slides. Okay, it's always a relief when that works, isn't it? So thanks again, Philippe and Raquel, for such a lovely welcome. I'm truly delighted to be here. And I note the last webinar that you had on Monday and the webinar planned next is really about going deep into single conditions. So what I'm going to do with you today is show you some breadth of how value-based healthcare implementation goes when you start to spread it across the country and it develops something of a life of its own. So I'm going to cover how I think about how we need to increase value in healthcare systems from a population perspective, from a pathway of care perspective, and from the perspective of people, of individuals receiving care. I'll touch a little bit on learning health and care systems and how we've taken data to knowledge to action in the Welsh system. And then, you know, value-based healthcare implementation is hard. It's hard work, and not everything goes our way. So I'll share some tactics with you as well. So how do we increase value for populations, pathways, and people? There are many different perspectives on value if you go around the world. And of course, we start probably with the book Redefining Healthcare that Michael Porter and Elizabeth Teisberg wrote. And there's a quote in there which says that value-based healthcare unites the participants of healthcare, unites them in a common language. And it's my favorite quote from the book, because actually a lot of what you hear people say about value-based healthcare would make you think perhaps that this is all about just quality improvement in clinical behavior, or you know, just something that happens between patients and their clinicians, or just about proms. And that's not true. It's a team sport. And in my experience, one of the most critical components of the team are actually healthcare managers, because managers are the fixers and nothing changes in healthcare without managers. So if you want to change your model of care and your manager doesn't want to do it, I can say it doesn't happen. So it is absolutely critical, and partnerships between managers and clinicians are really where the magic happens. And the other quote that I like, the other perspective on value I like, is this one from an allied health framework in Queensland, Australia, from a couple of years ago. And they say that value-based healthcare it's a way of thinking, it's a lens through which we look at problem solving in the system, not necessarily a set of processes that we blindly follow. This is a toolbox that we use to problem solve together for higher value. And we can do that at a population level. So thinking about segments of the population having similar needs, and how we may address those. And that's very important, because we don't want to, as we implement value-based healthcare, drive up inequalities in health which may exist. So a population approach is very important. It's also very important when we think about health technology assessment and how we introduce new technologies to the healthcare system, for example. And then more traditionally, in terms of value-based healthcare thinking, pathways of care are critical. And when we talk about pathways of care, we are, of course, talking about the whole pathway. So from prevention through to end of life, sometimes where that is relevant. And then, of course, down to what matters to individual patients and how we meet individual patient needs. So let's zoom in on a pathway. So obviously, most healthcare pathways are not linear at all. Especially when you get into the follow-up phase and the supportive phase of care. People are coming back and back, often when they have chronic disease or cancer, but we make a linear representation because it's easier to analyze, isn't it? So we really do need to do that forensic analysis at each step of the pathway as far as we can. So obviously within a hospital, you may have a shortened pathway, and to extend across the whole pathway, you may have to collaborate outside of the hospital with primary care and social care and so on. But we need a forensic analysis if we're going to really and truly improve patient outcomes whilst utilising resources more effectively. And it follows, therefore, that higher value interventions tend to occur at the beginning of the pathway, because if you prevent somebody from having a disease, clearly that is the highest value of all. But then we want to really optimize timely diagnosis and optimize the intervention, whether that's surgery or drugs or whatever it happens to be, and then think about the best way to follow patients up in the second half of the pathway. And we can really think about that in a very different way using value-based healthcare principles. So a lot of the work in Wales has focused on moving away from traditional models of follow-up that just have arbitrary time points between the visits that patients make to the hospital, for example, and start using outcome data and patient-facing technology to enable flexible access to clinical teams. Often that's patient-led as well, so that patients are seen when they need to be seen, and are left alone when they're well. So this allows a much more flexible use of resources in the second half of the pathway. And then on, of course, into palliative care for chronic degenerative diseases and cancer is very, very important, because there is a lot of harm that can be done if we over intervene during that phase of the pathway. So value-based healthcare and generating a good outcome with patients is more than just having excellent processes of care and an excellent technical intervention, of course. It is also about supporting patients to be involved with their healthcare, because generating an outcome, again, is a team sport. So we need to be thinking about, as healthcare systems, how we put patients in a position where they are able to have the best outcome through thinking about how we raise health literacy, how we give patients access to their own data and digital tools to help them with self-management where that's appropriate, to support their individual goals and preferences through shared decision-making, and really looking at how we optimize quality of life to the best that it can be, no matter what is wrong with somebody. It is really, really important. And these things are not soft interventions. They are just as important in achieving a good outcome as the technical intervention itself. So from our side, on the healthcare professional side, we need timely access to evidence-based interventions, of course, but it's how we invest in time and resources to support that self-management, because supported self-management is a major, major factor in generating a good outcome, whether you're having a hip surgery or whether you've got diabetes or whether you've got cancer. It really doesn't matter what the diagnosis is. So how do we challenge ourselves also on increasing value on the healthcare side? Well, it's not just about increasing high value stuff, of course, it's about also reducing low value things. So doing the right things well, decreasing unwarranted variation. For example, if we think about managing diabetes, there are 9 processes of care that we know have such a strong evidence base in terms of reducing adverse outcomes, adverse clinical outcomes, and adverse patient-reported outcomes. So we have to reduce unwarranted variation in care and really do the basics well. That's a fundamental pillar of value-based healthcare. And we need to reduce low-value care. And low-value care can take many forms. It can be as simple as an appointment that a patient doesn't want or need, that doesn't contribute to the outcome, but still consumes resources in your organization. Or It could be a procedure that now has a lower evidence base or doesn't improve outcomes very much. But also we need to adopt high value innovation. And we know that as healthcare systems, we're very slow to adopt high value innovation, often because it's seen as a cost pressure within one department. So again, if we think about diabetes, you know, the new technologies in diabetes have such a strong link with better glucose control, and therefore reducing amputations, reducing eye disease, and the very high costs associated with those things. So a lot of the work in Wales has been about the two sides of that coin: reducing unwarranted variation in care, driving the adoption of high value innovation, but also looking at this issue of releasing staff time, clinical staff time, and creating capacity in the system through digitally enabled new models of care, many of which are also increasingly supported by patient-reported outcome measures, and I'll explain why in a moment. And also, we need to focus on meeting true need, reducing inequalities in health, and a focus on prevention, especially secondary prevention. So why secondary prevention? Well, in Wales, I couldn't really get anybody to invest enough, to my satisfaction anyway, on prevention. And this is because it is a long time horizon to see the return on investment, I think. And so we all focus on the immediate in front of us. But secondary prevention gives a much shorter return on investment. So the example I want to give you is in fragility fractures. So older people fracturing their hip after a fall is a very common problem in our societies. And we know that these fragility fractures are caused by osteoporosis, and that the risk of having a second fracture, if you survive the first one, your risk of having another one is very high, and your risk of disability, permanent disability, or death is even higher the second time. So secondary prevention, through creating a fracture liaison service that picked up those patients who had had a fracture, optimized their osteoporosis medication, and put them on a falls prevention program, including exercise and so on, has been incredibly effective. And the clinical leader who has led that, it is a Wales-wide project, he has done that through value-based healthcare. So it's a really great thing. So value-based healthcare is a data-driven discipline, of course, and collecting outcome data is rightly a strong focus when we think about value-based healthcare implementation. And like everybody else, we developed dashboards, and lots of dashboards. And then we realized that nobody looked at the dashboards, or people didn't look at the dashboards very often. So my fetish for dashboards was not shared. And of course, it's because we're all really busy, and what people really want is actionable insights from the data and triangulation with other data points, so that we know what to do with the data, and we can keep the dashboards for the enthusiasts, perhaps. So data transparency is very, very important. We have to be transparent with our data and share with our colleagues. Otherwise, how do we know how we are performing relative to anybody else? And what you see on this slide is a representation of some clinical indicators at different stages of a pathway. And obviously, if the dot is in the red, it's not so good compared to everybody else. And the higher you go up into the dark green is the better performing. So this visualization allows us to assimilate a very large amount of information very quickly, just like that. So you can see that on the top, Cardiff Health Board, CV, UHB, performs really, really well, except for that last indicator, which is right down in the red. and that one happens to be percentage of surgeons delivering fewer than 10 procedures over a period of time. So it's not an outcome, but it's an indicator. But you get the idea that how we present data points is very important for how we consume data. And that's been a very big lesson for us in Wales. And this methodology is actually from the Scuola Sant'Anna in Pisa in Italy. And it would be great for them to do a webinar for you if they haven't already, because they're fantastic. And value-based healthcare, of course, is not just about PROMs. We need to be looking at PROMs, clinical outcomes, some process indicators, and obviously costs. And what we found is it really kind of depends on the problem you're trying to solve, what data set you bring together in that context. So we also found that key data insights from clinical registries and audits must be visible and actionable. And the problem we had there in Wales was that the clinical audits and the clinical registries were all housed somewhere else, like in a university, and the university held on to the data, and we had a report maybe once a year. That's useless, right? You need the data. You need to own it in your organization. It needs to be transparent so that everybody can trust it. And you need to be able to triangulate it with other data to solve your problems today, not somebody else's analysis in a year's time. That can happen as well, but this is why we need homegrown data. So outcomes, clinical and patient-reported outcomes, are very often thought of as results of something, results of an intervention. But actually, they're also a kind of milestone on a journey for that patient. So it's important, even if you do nothing, to track these indicators, because it is the patient giving you a status report of where they are at on any given day. And that makes it really useful in lots of different ways. There will be nuances around how we use the data in episodes of care, like a cataract surgery or a hip replacement, compared with a chronic disease like heart failure, Parkinson's disease, or diabetes. But at an individual level, these things are so useful as a symptom tracker. So, for example, in heart failure in Wales, we've used the Kansas cardiomyopathy questionnaire quite extensively as a symptom tracker that both patients and clinicians see, and has been very useful for guiding their care in a number of different ways. It can also flag up triggers for key conversations. So again, in heart failure, they found that they were able to identify when advanced disease patients needed palliative care, and as a tool for shared decision-making in whether people should have a procedure or not. And where we would like to get to in Wales, as I think probably in the rest of the world, is to be able to say to a patient, we think somebody like you is likely to have this outcome, not just the average outcome from somebody in a randomized controlled trial. So, but the point about that is you only get those big data sets if you are using these things in direct care and they are useful to patients and their clinicians. So the symptom tracker bit is the key bit to start with. And then when you start to get your data sets and aggregating outcomes, you can see variation, and you can compare each other and see how you improve your outcomes. But actually, working in a public health system in Wales, what I was most struck by was how it showed unmet need, and how we needed to change the way we delivered services to meet those needs, to improve those outcomes, and therefore reduce resource utilization, whether that was finance or human resources. Really, really important. So then it informs resource allocation and contributes to that real world information I was hinting at earlier to help patients make their decision, and ultimately real world information to help us understand how well high cost drugs are working and so on. So this is the way we've really built it up in Wales. So here are a few examples of how we've used patient-reported outcomes alongside other data. So just like Portugal, we participated in the OECD Paris programme, and actually I feel like I'm amongst friends today because we kind of came out at the same spot. But I don't think that's a bad thing, and maybe we can talk about that in the questions afterwards. We had a long COVID service that was designed in Wales at the end of the pandemic, and we had no idea if it would meet people's needs or not, because long COVID was a new thing. So we did an evaluation using PROMs and clinical outcome data. We were able to prove that it had been highly effective in improving the outcomes of patients, and that led to the case being made for a longer term service. I absolutely know that if that data had not been available, that service would have been cut 100% in the current climate in Wales. So that's a really powerful example for us locally. And then we've also used PROMs to support pathway reconfiguration. So there's a fantastic case of a public-private partnership between the university and hospital to increase capacity for echocardiography for people who have recently been diagnosed with atrial fibrillation. And the PROMs there, triangulated with the ED attendants, showed that the very rapid access to echocardiography, so we could reassure patients their heart was structurally normal, led to such a reduction in anxiety and symptoms that they almost eliminated repeat attendance at the emergency department, with all the attendant reduction in cost that enabled. So again, another powerful intervention, and also, as I mentioned earlier, supporting individual care in heart failure and making sure that we were able to very rapidly optimize people's therapy. I'm definitely not going to go into PROMs implementation at scale, Philippe, don't worry. Just to say, it's hard, but it's doable and it's worthwhile, and interoperability is the key. And I'll just leave that there as a placeholder, because that's a topic for a webinar all on its own, I think. So just to conclude, before we get into some chat, I just wanted to share some tactics, which I found helpful, because a lot of this is swimming against the tide, swimming against the KPIs, the key performance indicators you may currently have, swimming against culture. So you need tactics, and that multi-professional collaboration is really powerful. So if in your hospital or your healthcare organization, whatever it happens to be, you can form a partnership between a manager, a financial manager, a clinician, and an informatician, then you have an A-team essentially, and you can conquer the world. And you can really start to use your organizational levers with the right data. And I'll explain now what I mean. In Wales, this programme grew from really a grassroots collaboration just like that, and grew over a period of about 4 years into a national approach. But then supported by 7 local value-based healthcare implementation teams in each of the health boards. So having your own little A team within your organization will really help you grow this across your organization. And then it's all about building trust and building community. So for me, this started with cake. And I'm not even joking. I would literally bribe my colleagues with cake and coffee in the hospital coffee shop until I persuaded enough people that they owed me cake and that they had to take part. So, you know, fair tactics or unfair tactics, everything is up for grabs. But then, of course, you start to build your community of practice a little more formally. And what I've found is that the clinical networks, once they get their teeth into this, they see how important it is, and they're really, really enthusiastic about it. So, of course, that grew for us into more formal learning through the Intensive Learning Academy. And then things like this, these webinars are so important. And then our monthly kind of podcast, which is available on YouTube and is freely available if you're interested. And that was really about problem solving and diving into you know, some of the solutions to the wicked problems of value-based healthcare. And then the final thing I want to share with you is this. So how do you put it all together to really tackle very difficult problems in the system? So one of the most difficult problems we've had in the UK in the last year have been ambulance handover delays at the emergency department. It's a big political hot topic. And if we're going to make a success of value-based healthcare, we have to tackle the big issues as well. So, so this was a challenge presented to me. And so what we did was we looked at the reasons for ambulance conveyance to the emergency department, and we segmented those and identified the top 3 segments by volume that were going. And one of the top segments, I think it was the second, were people in their last year of life with palliative care needs. And this was a tragedy for them because they were not having their needs met in ED. It was a horrible experience. But they had no choice because their symptoms were not being managed at home or in another setting. So this wonderful collaboration came about with the digital guys, the ambulance professionals, the paramedics, and the palliative care community to create a last year of life dashboard, which looked at outcome data, experience data, and hospital admission data and ambulance data to identify and quantify that unmet need in the last year of life. And that has led to a white paper from the palliative care director to set out how we start to address that unmet need in a different way, because this is how we tackle these big problems. It is getting back to the root cause and using value-based healthcare as a methodology to help us to do that. So this concept of value-based healthcare being something new and nice to have over there needs to go away. It needs to be here, front and center, helping us solve our problems every day. And I think that is my last slide. So where will you begin?
Thank you very much, Sally. It's always a cleanup in our head, you know, to see so much definition, and that's the difference about people that have been doing it. You know, we go specifically to a point, and we know, yeah, exactly, that's the thing. And I want to compliment you because it resonates so good when we are talking about unwanted variation, which is something that people don't usually talk about, the culture, organizational implementation. One of the things about talking about return on investment, which is people think that is very easy to go it for a long-term pathology and the part of transparency. And yeah, I would open now the questions on the Q&A. Please feel free now to open the questions. If not, I also have a lot of questions, and Raquel, please join in if you want to make some questions also. So everyone that needs to be, but yeah, I will start until people start talking. Do you know, Sally, what was the main barriers that you found when you started going on this journey?
The main barriers, I would say, were culture, technological. So at culture and change, number one. Number two, technological, acquiring the data, understanding what software was needed, and you'll understand this was 10 years ago, so hopefully things are a little better now, but I think, you know, some of the technological challenges are still real for many places. And the third one, I think, is organizational how can I describe it? Structures, decision-making structures, and performance indicators. So actually, the father of value-based healthcare in Wales is a guy called Alan Brace. He's now retired, but he was a director of finance, and he helped me because he said, Sally, I want you to make this organization a value-based healthcare organization. You do not have to follow any of the decision-making processes we normally follow in this organization. You do it, and if you have a problem, you come to me. Well, honestly, it drove everybody mad. And I was, yes, people didn't like it. A lot of people didn't like it, but it was critical to not getting stuck in the treacle of slow, you know, it was a very, very useful thing that he did. So those would be, there are lots of challenges, but those are my top three.
Yeah, great. Do you feel that you need a value-based healthcare team inside the organizations or above? What your perspective? Because you are the few in the world that have a view of a politician and a policy approach, which is very difficult to get among a lot of. What's your perspective on that? You know?
Yeah. So having been a general practitioner for a long time and run my own business, and then I was assistant medical director, so I could see it from an organizational perspective, from a healthcare provider perspective, absolutely. And then as a policy advisor, everything I've learned has been the hard way and doing it wrong first, believe me. So you absolutely do need a value-based healthcare team within your organization. Now, you can repurpose a quality improvement team. You know, you will have people doing improvement within your, as long as you do an assessment of the skills in that team, that they have the proper training, and that you plug the gaps if there are any skill gaps in that team. You don't need to build another thing, because I recognize that these things cost money. So you don't want to build an empire, and that was never what this was about. But you do need someone who is driving that change. Otherwise, as you know, Philippe, it won't happen. And at some point, there's an awful lot you can do as an organization on your own. And at some point, there needs to be alignment at a policy level. But my way of getting around that is to take policy documents for bedtime reading and read every single word, and then find the words that relate to value, and there will be some, and you hang up what you want to do off that. And then if there's any challenge from the center, you say, but in your document, you talk about improving outcomes and you talk about reducing costs. So come on. So at a policy level, it doesn't matter if they don't have a dedicated value-based healthcare policy, although that would be nice. You can find things to hang off, but you definitely need it in your organization.
Yeah. So starting to pop some questions. One is technological today collaborating across the entire healthcare ecosystem to map and evaluate the patient journey, and with that find out where value is best created for patient, therefore to improve processes. So
yes, absolutely. What I would say is that is a really big undertaking. So at the beginning, for example, one of my colleagues was tasked with doing time-driven activity-based costing for every single cataract pathway across Wales and every single prostate cancer pathway across Wales. Well, honestly, it took him a year. So it's too long. So you don't have to do the whole pathway all in one go. You will know from your existing data and from your experience where the problems are. I would start with the problem and then start to dig deeper into that problem from a value-based healthcare lens. That's the way I would do it. But there are some common things. So the prevention diagnostics bit is key, clearly, getting people, and prevention might be outside the scope of the hospital managers, that's fine. But what about secondary prevention? Is there something that your pathway should be addressing to stop patients coming back to you? Or do you need to interact with other stakeholders to tackle that? And then this whole piece around outpatient follow-up, I would absolutely look at that. There's huge value to be added there. But you don't have to do it. You don't have to eat the mammoth all in one go, is what I would say.
Okay. And do you feel before, yeah, Raquel, do you want to join in?
Yes, I would like to comment on that because Sally, thank you so much for this presentation, and it touch pointed so many points of interest and that we have also have in common. I'm not sure that you are aware that we change our organizational and our governance model here in our national healthcare system. So our healthcare units, they are now integrated with primary care units and hospital units. Yes. But I was listening to you talking about the dynamics on the prevention and integrating the prevention in the pathway.
Yeah.
And I was thinking that in terms of value-based healthcare, this can be more defiant and scary at some point because it makes the process more complex. Because also in terms of the global perspective, we as a healthcare manager are more focused on hospital issues and the problems, so-called problems that we need to fix. And we have our ecosystem, which we are more comfortable in, hospital domain. And when we focus on all that is new to us, meaning in the primary healthcare units or the prevention setting or hospital at home, a new way of handling care,
Yeah.
this touch points dimensions that we are not so aware so far. So this is quite a challenge. Regarding prevention, what do you think that we need to be more focused on as we start on going into this, developing this model and being able to use the data, collected data from the population and not only from the patients at a hospital setting? What would you recommend us to look in the first level of action?
Okay. So I did know you were moving towards an integrated system when I came to Portugal a couple of years ago. So it's really nice to know that that's happened. And it is actually really hard, and it takes a long time for that integration to truly occur. So that happened in Wales in 2009, and I'm not sure we're even 100% there. It's very difficult. So population health data, which I think is what you're really talking about, to help with that whole pathway piece and the whole and the prevention issue. Finding ways that you can amalgamate your primary care data set with your hospital data set is really useful. We've found that challenging at times, but we've found ways around it. And I think the other thing which helps is to find a common priority. So to find an issue which really hurts everybody, really. So I'm going to pick type 2 diabetes because I'm guessing, well, I know in Portugal you have a high prevalence. I think it's about 10%, somewhat similar to us. Yeah.
I think it's a little bit higher.
It's even higher. Oh my goodness.
I think so. I'm not sure, but it's a huge problem.
Higher, and it's sub-diagnosis because we have people that don't go to primary care. So you don't even know if they are diabetes or not.
Yeah. So this is a really big deal. So, but it's a big deal for primary care, it's a big deal for patients, it's a big deal for secondary care, because just that fact will mean that in the public health system, you will be having a load of hospital admissions that you might even not be registering as being related to diabetes. So I did an analysis on this a number of years ago and found that you know, so many infections were actually driven by diabetes, for example. That's even before you get to amputation and the rest. So having a project that draws the organization together around a population health issue is a really good place to start, because then people are willing to start to contribute to that data collection, more so than if it's just your, or appears to be just your issue, if I can put it like that. And that certainly has been the way we've tried to do that in Wales. And then the other way in is this secondary prevention issue that I mentioned earlier. So fragility fractures is one. Alcohol liaison services were another, which seems like a bit of an unlikely value-based healthcare topic, but actually was hugely successful in reducing ED attendances for problem drinkers with head injuries and so on before they got to liver disease and the other consequences of excess alcohol. So it's really good if you can start with what the organizational pressure points are, or things that are of common interest right across the professionals in your new integrated care system, and don't try and do it all, just do one, and build that trust and build that confidence, and then it starts to happen.
Yeah. I have some final questions for your last minutes, okay? And I think this is a very precise question which I liked it. So in Portugal, the majority of clinicians have no idea of the costs related to their procedures. Should we talk about costs or with our medical doctors, or should they only be focused on giving the best known response treatment? That's a very good question.
It's a really good question, and I can answer that one very quickly. Yes, absolutely, we should know the costs as doctors, because we have a responsibility, I believe, that to the patient in front of us and the patients who have yet to come to us but will come. So an individual responsibility and a population health responsibility, and everything that we do displaces something else potentially, even in a private healthcare system. So absolutely yes. And there's a lot longer answer to that, but maybe that's another topic for another webinar.
Yeah, absolutely. She was also making the quick question, how many KPIs do you monitor in each department or clinician?
It depends. It depends. It depends on the issue, depends on there's no set number. Before I left, we had really embarked on that, trying to look at indicators from each of the 5 segments of the generic pathway. So looking at prevention, looking at diagnosis, optimizing, you know, those 5 things to make sure that we didn't miss out any key part of the pathway. Because if you don't do that, the cultural tendency we all have is to focus on the hospital, right? Because that's where the emergencies happen. So it's really normal, but if we make ourselves do that, then we can start to improve performance overall, and that reduces costs.
Yeah. So Sally, I could not thank you more about the huge knowledge that you always bring. I'm sure that Portugal and the world will keep seeing you very shortly, and you'll be much more closer to us. And I think that's going to be a huge reality. Thank you very much again to bring your knowledge into this. And now end it up, Raquel, to finish. Okay. Thank you, Sally.
Thank you.
So thank you again once more, Sally, for being with us this afternoon. Philippe, thank you as well. Tomorrow we will have our 3rd webinar, also with a great topic and more to think about. Hopefully the ones that are attending, this is a call to action. So a lot of ideas, a lot of brain here, promoting what we can do, the projects and ideas that we can do best to implement in our country. This is what this program is for. So thank you all for joining us tomorrow for our last webinar. Thank you all and good afternoon to you all. Thank you. Bye-bye.
Obrigada. Bye-bye.
Bye. Thank you.